Hey now, welcome to the Inside BS Show. I am Dave Lorenzo, the godfather of growth, and I'm here with my best bud and my co-host, Nikki G. Hey, Nikki G, how are you?
Hi, Dave. I'm doing great. How are you?
I'm doing fantastic. So, Nicola, I had an aha moment when I first became an entrepreneur. And that aha moment was when I had to schedule a doctor's appointment. And I scheduled the doctor's appointment, and I'm like, well, wait a minute. How am I going to pay for this? it turns out when you work for somebody else, you don't even need to think about that. Sure, when they sign you up and you go in to HR on the first day or the second day, you get like a bunch of choices and you're like, I don't know which to pick. And they say, do you go to the doctor a lot? If you go to the doctor a lot, you want this plan. Do you go to the doctor a couple of times a year? If you go to the doctor a couple of times a year, you want this plan. And that's kind of how you pick your health plan when you're on your own. And then when you have a family, what I did was I said to my wife, make a list of all the doctors, right? And then you go into HR and you're like, which plan has all these doctors in it, right? And that's how you pick your healthcare plan. Well, you become an entrepreneur and it's a whole new ball game. What did you do when you went from working for a regular law firm, a good sized law firm, to being in your own law firm? Did you have the same epiphany that I had? Like, oh boy, this is going to be a whole series of decisions that I wasn't ready for.
I really didn't, Dave. I'll tell you why. Because the decision made itself for me. There was one option. That's it. At least that was what was presented to me. There was one option for you as an entrepreneur. And given my age and my gender, it was a quite expensive option. So that's what I had to go with. So I really didn't have to do much thinking. The thinking was after the fact of which doctors can I use. What I cared most about was, look, I have at least two doctors. We got to make sure they're covered. So you figure that out, even if I only have one option. But I'll tell you what, even at a bigger firm, and not just my firm, it was all the companies I worked for. When it came time for enrolling for the next year's worth of benefits, we never really had someone sit down and answer questions. It was, here's all the stuff. We're going to give you this a week in advance. Look at it. If you have questions, someone will be there to answer those questions, but basically you need to pick what you're going to select. And there wasn't much involved in that process, and it was very painstaking for employees.
Yeah, there's no real good answer, right? Because especially as you get older and you have more frequent trips, or if you have a family and somebody has to go see a specialist, you realize very, very quickly that there's either pain today or there's pain tomorrow. And you're just choosing between the two. So, this is important for anyone who's leading a business, who's growing a business, or who's selling a business, because it used to be healthcare was a recruiting tool and was a competitive advantage. Both of my parents worked for IBM. My dad for 40 years, my mother for 18 years. And with IBM, all your benefits were always paid for 100%, at least while we were growing up. So we would go to the doctor and the doctor would say, you got to see a specialist. And we would just go see the specialist. We wouldn't think twice about it. There are people out there, and I know them, you know them, who they have to go see a specialist and they got to wait until they get paid by their clients to go see the specialist because they got an out of pocket they have to cover. The reason that we're talking about this today is because of our guest. So why don't we get into what we're going to talk about and why we're going to talk about it? Take us through that.
All right, so I think we have absolutely teed this up for our guest today. Our guest today is Donovan Ryckis. Donovan is the founder and CEO of Ethos Benefits, together with his wife, Chelsea. And we are bringing him on to ask so many questions that we know our audience is really interested in hearing. And in my view, we found someone in the market who is really shaking things up in the healthcare space, in particularly with employee benefits. So it's a pleasure to bring on our guest. Good afternoon, Donovan. How are you?
Doing great. Thank you for having me.
It is a pleasure to have you. So Donovan, I'd like to begin with how you got into employee benefits, because you weren't working in that, even in that industry, the healthcare industry, when you first started out. You were working in the securities field. So tell us what really, I think, pulled you into this position.
Yeah, it's certainly a strange industry to get into. I mean, in your guys' intro kind of teed that up perfectly as well. Like, why would anybody want to get involved with an industry that has served people so poorly over the past 20, 30 years, right? Costs go up, your out-of-pocket expenses go up. It gets increasingly confusing to even navigate. And then even worse on the side I work with, on the employer sponsored healthcare side, it's line item number 2 or 3 on their list of expenses, and it increases every single year. So not a super exciting industry to join. I was actually on the security side, so I had my own registered investment advisory, and I was working with business owners largely on 401k and pension plans, and really loved serving that client. But after a few years, I started to realize while I was serving my ideal client, I wasn't solving their biggest problem, because over and over, healthcare came up as a bigger pain point. So, kind of on a whim, I took a request from a client to look at his healthcare, and he said, "Hey, my broker said this is it. I'm going to pay 40% more. Will you take a look at it?" And I really liked the client, and I said, "Sure, I'll take a look at it. Send me everything you have." And I phrased it that way because I had no idea what I needed to solve this problem, to figure it out, to understand it. But he sent me everything he had, which turns out is not a lot. Coming from the security side, I expected a list of claims and every penny they had spent throughout the year for all of their 120 employees. And that didn't come. Basically, his carrier had described that he's going to pay 40% more on one page in about 2 paragraphs. So I took a couple weeks, met everybody I could in the industry, started kind of going through that problem, mitigated that increase for him entirely, and realized that just like other areas of financial services, misaligned incentives can dictate the suggestions and the proposals that are coming out to you. And that kind of seemed despicable to me, that not only that cost would go on to the business, but also every single worker on the plant and their spouse and their dependents. So what I found out is while securities has kind of fiduciary designations where those advisors are acting in the best interest of their clients, no such thing in healthcare, still to this day. So that's kind of what brought me over to this side.
And I'm glad you touched on that, because that is really what stood out to me in our first conversation together, Donovan, was that fiduciary first approach to what you do, at least what the one that you and your firm take, that we don't see so much about in the market. I mean, I can tell you, you ask anyone about healthcare, they might not even know, and they're certainly not speaking about fiduciary responsibilities in that space. And I think that really relates to your why, and truly why you moved into this space completely and started doing this for a living. So touch on that a little bit about that fiduciary first approach.
Yeah, to me, it was just common sense. I mean, when I was starting in securities, even this was pre fiduciary rule, so like pre 2015 when that got proposed. But to me, that just made sense. Like you're taking people's life savings, often in financial advising and wealth advising, and it just seemed like the only logical way to present. I also figured like, hey, I feel like most of the people out there don't even understand this difference and what it means to them, and like how their current advisor gets compensated. So if I can start a conversation with education on kind of the fundamentals, and build that trust, that'll lead into more trust, and I can continue to kind of do good work. And same thing in healthcare, right? And it just makes sense, and it just seems so wrong that that's even allowed. Like at the end of the day, like the brokers or consultants, I mean, they're typically called like benefit brokers, right? Like they just hold an insurance license, and the standard of care is a suitable recommendation. Any product that's licensed to be sold in the state they're in is suitable to be sold. Doesn't mean they're serving their clients well.
So, Donovan, there's two aspects of this I think about as a business owner. The first aspect is cost, and then the second aspect is being competitive in my industry. I cannot afford to have someone not join our team because we don't offer at least comparable benefits. My preference would be to offer better benefits, but until we're in a place where we have over and above what we've promised to the investors that we're going to return to them, my first responsibility is to return what I committed to my investors. My second responsibility, of course, is to take care of my employees, and I want to make taking care of my employees a competitive advantage. in your business, how do you counsel your clients to balance the two? Because in my experience as a consultant, very few people put any weight at all on being a competitive advantage from a healthcare perspective. They're just like, how can I make sure I don't kill myself here? How can I make sure that people don't run away? So how do people benefit? How do CEOs balance the benefits and the cost aspect of this?
Well, the funny thing is it goes against the way they're currently understanding and dealing with the problem. But the truth of the matter is when you do this right, you can get both at the exact same time. Because the problem is how they're approaching the situation. They're hiring a broker who wants to broker a risk transfer. However, if you're dealing with risk, that is the most expensive option and path to deal with your healthcare risk. So the first strategy you'd want to do is look for what kind of healthcare risk can we avoid? What kind of healthcare risk can we reduce? What part are we going to retain and then what are we going to transfer? The problem is they're hiring brokers and the only mode of compensation is transfer, right? So they're looking for the biggest transfer. That didn't work. I'm going to transfer it to another company, Blue Cross, United, Cigna, Aetna, right? However, that doesn't fundamentally solve any problems. We're not looking at the supply chain. We're not understanding the costs and the drivers of the plan. So you can actually do both at the same time if you look at it like you would any other business unit internally in your business, right? You wouldn't, if you were a builder, you wouldn't just look at your construction costs or your supplies as like wood, right? End of the year, wood. No, you would know the cost of your 2x4s and your plywood and your 4x4s, and you would benchmark those, look for new supply vendors if those costs start to increase. Same thing with a healthcare plan. And at the end of the day, what employers are looking at is one number at the end of the year, once a year. But what's happening every day throughout the plan year is their employees are incurring claims. So what we see on average is 18 claims per insured employee per year, which sounds like a lot because you're like, well, some people don't use it a lot at all, right? But then some people have kids and a spouse and they go to the pharmacy every month, right? So the real question is, what are we paying for those claims, understanding that a claim is a request for dollars. It's not a medical condition. And I think we all know in this country the price of drugs is wildly inflated and variable, and the prices of hospitals are largely made up and definitely variable.
So, Donovan, you have a pretty good track record of lowering costs in this space. And if I have this right, it was something like 30 to 40%, especially when we're looking at heading towards an exit and increasing a multiple. Tell us kind of some of the things that you focus on to be able to do that.
Yeah, you're exactly right. It's usually 35 to 42% reduction in premiums. And it goes back to that same kind of risk matrix that I was describing. So, I mean, the first thing we'd want to do, I mean, I always say, like, what's the right amount of people if you're a company to have on your healthcare plan? I'd say the ideal amount is 0, right? Now, it's a little bit, tongue in cheek, right? That's assuming we were like any other country in the world where healthcare is not the employer's responsibility. So if the employees were taken care of and they had good healthcare, would you want to jump in and take care of that if you could show them a path? No, probably not, right? So like one of the first things we're doing is under that risk avoidance. So just basically saying like, where might people be better served that they don't know? So there's a couple easy categories. First one's COBRA, right? So COBRA is, when you term an employee and they want to maintain the coverage. Now, while they're an employee, you are probably paying for 90%. Now, when they go on COBRA, they have to pay 100%. The only reason they're going to do that is because they expect to incur way more claims than they're paying out. That's a really easy thing. When a person terminates, they would almost always get cheaper coverage individually on the ACA. So that's a proactive step that we take, because that one person on your plan that is termed will incur somewhere in the range of 5 times the amount of claims as any other member, right? Same thing with Medicare. You've been paying into Medicare for 30 years, 35 years while you've been working. If you turn 65, it's almost always cheaper for you to start collecting on that benefit. It doesn't get better like Social Security if you defer it. So you could take Medicare and continue to work, right? So it's taking strategies like that. Another easy one, if you think of pharmacy, we often set up employers with mail order programs from Canada, UK, New Zealand, and Australia. Tier 1 countries, higher standards than the FDA, and they can mail order the exact same drug from the exact same manufacturer through those pharmacies at zero copay for the employee, and the employer pays 50 to 80% less depending on the drug. So it's really about focusing on the costs that are coming through instead of being a broker and just looking for somewhere to place and transfer that risk.
So let me ask you about that, because people are going to hear mail order pharmacy
Mhm.
and they immediately think of midnight infomercial for Viagra, right?
Mhm.
So talk to us about how how does somebody select a reputable pharmacy from Canada, UK, New Zealand? I mean, I'm sure this is a service that you provide, but if somebody's
Yeah.
listening to this and they're like, that's genius. If
Mhm.
I can save 40%, and they're immediately, I can hear keyboards right now with
Yeah.
either ChatGPT or Google, Canadian mail order pharmacy, and these people are going to be haunted by Cialis ads for the rest of their lives. So how do you do that?
Right. So basically, like what I'm helping doing is creating a custom healthcare plan. So mail order pharmacies exist in every healthcare plan right now. The difference is that the insurance company owns the pharmacy benefit manager that's setting the price of the drugs, and then they also want to fill it through their own pharmacy, and then you're paying for the profit margin in each one of the supply chain that's vertically integrated. So we can do the same thing just in a better way, right? So in the healthcare plan, we just establish a contract with a pharmacy in these countries, right? So it's already set up. So the way it typically works is if a member were to go fill a drug, they go to Walmart or wherever they go to CVS, Walgreens, whatever. We would see that drug come through and then we would alert them and say, hey, you just picked up this drug. If you want, we have a mail order program where you can have it delivered to your home. It comes from Canada. Currently, you're paying $150 copay because it's usually going to be the high cost drugs. You can continue to do that, or you can set it up through the mail order and we'll ship it to your door at no cost. So it's not punitive, it's there. People do it because it works for them. Typically they're saving 2 grand, maybe more in copays. And again, the plan gets that benefit as well. So we're just kind of establishing these rules for the healthcare plan. We're creating that in the summary plan documents, and then we let the plan operate. Because these things are happening anyway. It's just in a way that doesn't benefit the plan participants or the plan sponsor.
So when we talk about a plan, you're going to the standard health insurers. It's just that the nuances of where all the waste, fraud, and abuse is, to use the term that everybody loves to use, right? You know where all the waste, fraud, and abuse is, and you cut through that, and you say, okay, United Healthcare, okay, Aetna, okay, Blue Cross, here's what we're looking for from you for employer XYZ. And you give them a spec. This is specifically what I want. Is that how it works?
Yeah, it kind of depends on the employer size, but essentially, like if we were to think of this simply, any healthcare plan basically has four moving parts. Okay. First one's just the administrator, that's called TPA, usually third party administrator. That's just like who's answering the phone, paying the bills to the providers, issuing ID cards, right? Second part is what everybody actually thinks of, which is the network. So they go and they say, I'm on this PPO, I'm on this HMO, right? So that's going to be the big carrier name. Third function is the actual insurance for the company. So that's the stop loss insurance, and that's what protects them in catastrophic claims and lets them set their premiums and their underwriting, and like they know what their costs are, right? And the fourth piece is the one that's kind of gotten the most attention. It's usually the most nefarious. It's also the easiest to fix. Pharmacy benefit manager, right? So a typical broker is just going to go to one of the four carriers, because let's be honest, there's usually only four in any given market. If there's more, it's usually an offshoot of one of those four, like it's a regional offshoot. So they'll go to each of the four carriers and ask those carriers to do all four aspects of that plan. When they do that, that carrier is designing that product to their benefit, right? Because we're going to be we're setting the insurance rates, and we're going to set your drug prices, and we're going to set the reimbursement rates at the hospitals and doctors that you're going to, and we're going to set the administrative charges internally in the plan as well. So what we'll do typically is we'll look to customize that. So we might say, hey, you have this same big PPO name that you know, but we're going to hire an independent third-party administrator so I can get access to 100% of the claims data so we can properly negotiate this. I'm also not going to let the insurance company put in their own pharmacy benefit manager, set whatever price they want on drugs, right? And when we do that, we'll put in the Canadian pharmacy so we can access cheaper meds if the employees want it. And the biggest benefit really is instead of going out to market for just 4 insurance quotes, if I'm looking at that stop loss piece separately, I can get 30 quotes. Maybe Nationwide wants to provide the insurance. Maybe Allstate, Sun Life, Tokyo Marine, MetLife, right? Like there's all these different insurance carriers that we can bring in to actually back the insurance for that company. So you go from a scenario where it's maximum 4 quotes to now we can come up with like 100 different proposals depending on how we want to structure this. And it's really where a lot of the benefit comes.
And I just want to clarify this mostly for our audience because I think this is really important. It's not that you have access to other carriers that brokerage firms do not. It's simply that you're looking at this and approaching this a different way.
Correct.
And especially when you mentioned like with a stop loss, I think it's a great example. Carving it out, sending it to other carriers, and in fact multiple more carriers, rather than just accepting the proposal you're receiving from these various carriers you are shopping this to.
Correct. Yeah, I could do it the same way. I mean, it's just that the most expedient way is to just say, hey, in our industry, we call them BUCA, Blue Cross, United, Cigna, Aetna, right? It's what exists in most of the country, and those are usually the only options. So I could send it out to those 4 and just do the same thing on repeat every 12 months. Or I could be a consultant and say, hey, I understand the cost drivers, and I know the employer can make better decisions for themselves, and I'm going to show them a couple paths, and they can decide what's going to work for them.
And oftentimes that's what we hear, right? Is the biggest complaint about someone's current broker is, well, I only hear from them once a year when it's renewal time. And we're already up against the deadline, especially with a cost of this magnitude, that's not enough time. So tell us kind of how often are you having those communications with your clients, or maybe it's probably regularly because you're consulting with them rather than just approaching it whenever the renewal's coming up and you're 30, 90 days out max and all of a sudden you're hearing from that person once a year. Because I think your approach is very different.
Yeah, it definitely needs to start sooner. And the trick of it is you're right, like it often is like an artificial time crunch because like carriers want to release it 90 days. Now, when that's a bad number, the carrier might hold it longer so they can see more claims come in so they can get a better number and firm up their underwriting a little bit. And then the broker sees it, they freak out, maybe then they put it out to other markets. So sometimes companies are left with 45 days, 30 days, and then they're like, well, now I don't have any time, right? So we're starting that process 180 days out. We're getting a firm renewal offer at 120. And then we're kind of giving the employer, here's our take on that 120 from this carrier. They gave us, and let me tell you, like there is no rhyme or reason to these. They'll pass us positive renewal increases, and without changing anything, we'll push them into decreased territory because we're looking at the claims and we're like, that's not justifiable. Like we're not gonna, without making plan changes, I've gone from like +3 to -8 just by saying like, no, like we're gonna look at the claims data here. That's not gonna work.
So yeah, let's get into that because if you have a good sized company, you often don't know how many claims there are through so explain how having that data is a huge competitive advantage. And here's what I liken it to. Tell me if I'm off on this, Donovan. So my wife worked for L'Oreal for a number of years. And when they would go to negotiate with Walmart would have better data on L'Oreal's sales than L'Oreal had. So Walmart knew what their customers were buying. Walmart knew what volume their customers were buying in. And it was a huge negotiating advantage because Walmart could say, listen, we'll pay a price increase on these products, knowing they're never going to sell any of those. And they would say, we need this much of a discount on these products because they knew that's where all their money was coming from. Is this the same type of thing because the employer doesn't see the claims, and now by making this change, you can see the claims and you can go to the insurance company and go, listen, you're gouging us. We know we didn't kill you with claims.
Yeah, for sure. Sometimes it's as simple as that, like the claims weren't even that bad, but more often you need a lot more detail because you'll look at it and say, let's use easy, simple numbers. Let's say $1 million in claims. You say, great, I had $1 million in claims. However, I can see 400K of that was one member and he left the plan 9 months ago. He's no longer a consideration for the year moving forward, right? So it could be something like that. Could be another thing. Great, we had $1 million in claims. 500,000 of them are in pharmacy from your PBM, which you're profiting on. I also know my top four drugs are highly rebated, and you didn't credit me with any of those rebates. You kept them for yourselves. That equates to about this much. And that's a huge amount as well. There's all kinds of different ways. So, unless you have a real look at them in real detail, you're kind of just pretty please lower it, like, oh, I might have to look somewhere else kind of thing. It's not an effective negotiation technique. You will get points every time, but it's not because you're winning, it's because they've already made up an inflated number knowing they're going to come down on it half. So like an everyday scenario with no data would be like they pass a 12, you get a 5. That's just every day. But if you're actually equipped with data, I mean, you could go from 12 to 0 to negative. And those are the real kind of scenarios of it.
So I think this is a good time to mention something, Donovan, that I know that you have done along with Chelsea is you put out a documentary really exposing my words, kind of bad practices out there in the healthcare industry associated with benefits. Talk to us a little bit about that.
Yeah, super proud of that project. So it's called It's Not Personal, It's Just Healthcare, like The Godfather, right? Kind of the healthcare experience a lot of people get. But it's about 70 minutes long. It clearly goes through kind of some of the problems in the healthcare market, employer-sponsored healthcare market, physicians, hospitals, drugs, all kinds of stuff. So I got to produce that with a bunch of people I've met and worked with over the last 10 years, going to healthcare conferences across the country where we all kind of get together, collaborate on problem solutions, bringing new things to the market. So you only see me in it for like 30 seconds. The rest is people on all parts of the supply chain, and it is a really good watch. It's really really compelling, and it's way better than most stuff you see on Netflix. So I'm still streaming it on my website, as we're in negotiation with streaming platforms, so you can get it at ethosbenefits.com.
Awesome. So make sure to check that out if you're listening. You know, Dave and I are big proponents of education in the space that you're operating in, and I think this is huge. Really shining a light on, understanding where some of this money is going, what some of the concerns and issues are. And I think at some point I heard you say you were kind of forecasting you may see a lot of lawsuits by employers in this space. You know, that caught my attention as a lawyer, and I've seen a lot of cases with PBMs over and I would say more recent years because of the massive amounts they were receiving associated with different plans.
Yeah, certainly. That's actually why I moved over to healthcare, because that was a part of what I was doing with my RIA. I was helping, employers avoid that kind of stuff on their 401ks, or trying to reduce costs and increase plan options and that kind of stuff. And when I saw healthcare, I was like, oh, it's coming, right? And it took 10 years, but it started last year. So January last year, we started seeing our first healthcare lawsuits come through. And to your point, it's exactly for decisions on the pharmacy benefit manager. So it started with Johnson & Johnson, 160,000 employees. They chose Express Scripts, which is Cigna's PBM, and the instances of overcharging for medicines that you could just walk in and get cash 13,000% cheaper than their plan agreed, literally 13,222% cheaper than you could just walk in off the street and buy it off the pharmacy for. So it's like the plan made a decision to allow that kind of payment. And what does that do to the employees' premium the following year, their copay today? Like, it raises costs for everybody. So we're going to continue to see that. And it's completely justified, and it's a very exciting time.
Let's talk about something that most people never get to talk about. And the only reason I experience this is because I've worked with a handful of family offices over the years. Why do people who pay cash pay less than my copay for going to the doctor, right? Like, so, and you can see this yourself if you have no insurance and you use like GoodRx, for example, and you'll end up paying in a lot of cases less for your prescription than your copay. Now, I'm assuming that with the prescriptions, it's the pharmacy benefits manager, which seems to be like kind of a basically, I'm putting words in your mouth. It's kind of a scam, right? Pharmacy benefits manager is like chief scammer in charge. But I think there's something absolutely wrong with the system when an affluent person can go to a healthcare system and say, I'm a self-payer. I can prove to you that I can self-pay for my medical care. And the system goes, well, all right, well, I guess we can't screw you, so we're going to charge you the real cost. Explain how that works, Donovan, please.
Yes, so that exists, and that's a strategy we actually use in our healthcare plans, but to use it for the good, right? So if we're getting a hospital that's giving us a ridiculous price, we'll employ that strategy. We'll cash pay in advance and receive that discount in the healthcare plan without the employee having to do it. So it absolutely does work. So think about this. Let's say you're a major carrier. I'm not going to name any names, not calling anybody out, but pick one, whichever one you like the least. When they go to a hospital system to negotiate, they have a couple buckets of insured people to negotiate. They have their Medicare people, they have their people on individual healthcare plans on the ACA, and they have the employer sponsored market. Now, when they're negotiating their rates for what they're going to pay for different procedures, basically they call those CPT codes, which is just a procedural code for anything you could get done, a Band-Aid or open heart surgery. Every number has a code and then a corresponding amount of what it's going to cost. So when they're negotiating those rates, they don't negotiate one rate for all three buckets of people. You want to know why?
Yeah.
70% of employers are self-funded, which means that cost is not going to be 100% on that carrier. So when they're negotiating rates for the same procedure, the employer-sponsored healthcare market is always going to pay more, and often 2, 3, 5 times more than somebody that comes in with Medicare.
So I actually have experience with this when we got an outrageous healthcare bill from a family member. I hired someone who's a consultant, and her whole business is to go through the itemized bill and line by line question the coding of the bill. And the insurance, what happened was we got the bill and the insurance company said, well, we're only going to cover this much. And I didn't even see, you never, as the end user, see the itemized bill. And I was like, our portion of the bill, because this family member didn't have the money to fund it at this time, we were going to have to cover it. Our portion of the bill was close to $100,000. And I was like, we're not doing this. This is ridiculous. And I knew this person was a consultant. I said to the consultant, can you help us? And she said, yes. And she said, here's how I'm going to help you. She explained what her fees were. And then she said, you give me authorization, I will get the bill from the hospital. And then I will go line by line and look at how they've coded everything. And first I will work with the hospital to fix the bill. And I said, how do you know there's mistakes on the bill? She's like, well, a mistake is when somebody does something by accident. She's like, I can assure you that there are things on that bill that were done to inflate the bill that were not accidents. She said, so once we get through with that, then we will go and look at the Medicare reimbursement rate, and we will negotiate from there. And instead of negotiating our way down, we're going to work from what the reimbursement rate for Medicare is and work our way up. And she said, most of the time, they're not going to want to do that. They'll just give us whatever the Medicare reimbursement rate is. Yep. And I was like, I was shocked. I was absolutely, she said, you're not dealing with people who are experts in negotiation here. She said, the minute that we get into this process, they're going to give us a bottom line number. Then, Donovan, I'm gonna blow everybody's mind even more. I went to a personal injury attorney, and I said to the personal injury attorney, okay, so you've got someone who is in a catastrophic accident, and they've got a $500,000 bill with the hospital, but they only get a $300,000 settlement. What do? He goes, I go to the hospital and tell them I'm going to give them 50 grand and tell them to go away. And I said, do they negotiate? He's like, no. He's like, they can't negotiate. He's like, they take the 50 grand and write the rest of it off. And I was like, what? They do what? So I didn't even know this was negotiable. I had no idea. So do these cash people, Is that what they do? They go to the hospital and they say, all right, here's what I'm going to do. I can put $50,000 in escrow. I'm going to have a heart procedure. How does it work with cash people?
I don't know about cash people. I mean, I suppose there's a lot of different ways you can do that, but we set those same principles up for employer-sponsored healthcare plans. So sometimes jointly, sometimes separately. Because if you're part of a PPO network, say you're part of one of the big carriers' PPO, part of that agreement is that that is a pre-negotiated rate for any service you could have done at any of those providers, which means you can't negotiate it because then they're going to kick you out of their network. So when you're participating in a network, part of the process we do include is the clinical bill review, which is what you're talking about, looking for ineligible, duplicate, error charges, right?
Upcoding, yeah.
And you'd be shocked what you get out. I mean, the last one I saw earlier this week, I think it was 136K, and I think we evacuated 22K of just ineligible before any negotiation. Just like these are all baloney. They need to go away. And then we started to the new points, right? So that's clinical bill review, which you certainly can put on any of the HMO PPO networks. You do have to do it at renewal. They don't want to do it. They will push back. It is part of negotiation. So like our process during renewal, we're gonna negotiate 3 to 4 times on price and twice on terms. So once they think we're done, we've agreed to a price, then I'm pushing on contract terms, which is clinical bill review, 100% raw claims data export to my analytics, stuff like that. The other thing you were kind of talking about was essentially a concept called reference-based pricing. And that reference is Medicare, because Medicare is the largest insurer in the country, and every provider, every hospital that's agreed to accept Medicare has agreed to those rates. So instead of letting the hospital make up this crazy number and then say, but we're going to give you a 50% discount, and then you're going to still be paying up here, we'll look at the Medicare rate and say, Medicare pays you X. And honestly, usually this sounds like a bad deal, but it's a great deal. We're going to pay you 140, 160% of Medicare. And that is still a phenomenal deal. I know you hear it, you're like, you're paying 40, 60% more in Medicare. Yes, because the PPO rate's 300, 400% of Medicare, right? So we're taking that reference point that you talked about of Medicare and going up to something reasonable instead of allowing them to make something up. And then being grateful for 50% discount at 400% markup. It's a game, man. The whole thing's a game.
Oh, absolutely. It
It's
absolutely is.
frustrating. It's rewarding when you do it right, but like often I see this stuff and it's new levels of insanity on a weekly basis on the silly stuff we see. And it's huge, huge impacts. And the funny thing that like plan sponsors don't understand is like, say you got 500 members, we might only like seriously need to work on like 5 claims during the year. But those 5 claims will make up 70% or more of your claim spend, right? So it's not about like handcuffing everybody and making them jump through hoops and smaller networks and higher deductibles. Like it's just when those big claims come through that we handle them appropriately. And same thing with the pharmacy. Like I reviewed one with a client yesterday. More spend was coming from what was it? It was like 60 or 70% of their entire RX claim spend, all their drug spend was coming from one person. And we had put that person through the international pharmacy and it was saving 100 grand. So it's a small amount that you need to do, but there needs to be a process for understanding the cost of these claims and then understanding how you're going to deal with them rather than just saying one number one time a year, which is your annual premium and the annual premium increase.
And let's talk about that one time, one number a year, because that also is related to how a lot of brokers are paid, right? Which is commission based, which is a percentage of the premium, so that every year that premium goes up, that commission goes up, which creates at least a perceived conflict there in terms of the compensation. So talk to our audience about that, because that's what they're most familiar with, seeing how that compensation is paid. And you and I have talked a lot about fee based.
Yeah, perverse incentives is how I like to describe them because if I'm getting paid every single more when your premiums go up, I don't want the worst thing for you. I'm just not going to work that hard to make the best thing happen either, right? So that immediately needs to be flipped. And if you're hiring a broker or a consultant, really you should look to change from a broker to a consultant. They can call themselves whatever they want, The biggest difference is going to be in how they're incentivized because, like you stated, like an employer would hire this person, but the insurance carrier is the one that incentivizes them, which is really what's going to drive behaviors, right? So basically, get that number disclosed. You want to ask them about direct compensation and indirect compensation, like bonuses and other enhanced commissions they'll receive through that carrier, and change it to a fee. Most typically it's a per employee per month fee because they'll be serving more or less of your people. But change it to something flat. And if that per employee per month is increasing, they better have gotten you better results or they're doing more services for you. Maybe they're handling a couple measures more of compliance. Maybe they helped with your benefits administration technology, right? There should be something positive that you're looking for them to get that pay.
So, Donovan, what's the size of companies that you work with generally? How big does a company have to be in order for it to make sense for you to get involved with them?
So nowadays, kind of our minimum size is usually 250 employees. But if you're hearing this, you're not quite there. I do have other agencies that I know that kind of do things the right way. Happy to make connections, introductions. But we're typically 250 minimum up into the like 6,000 employee range.
All right. So, what's the generalized advice? So, anybody with 250 and up should call you, and we'll put your contact info in the show notes. We'll get you to give it to us at the end of the show. What's your general advice for people below 250? They just gotta kind of bend over and take it from the current brokers, or is there an option for them?
Yeah, certainly not. I'd say the first thing they should do is get themselves educated on the Consolidated Appropriations Act of 2021. I know it's a mouthful, but that was legislation like that's been in effect since January 22 is when that, kind of started. But it basically set forth minimum standards that employers need to do to pretend to be a prudent fiduciary. And whether they know it or not, or like it or not, if you're making these decisions on behalf of your company, you're a fiduciary for the welfare program of your company. So really simple measures. First one's compensation disclosure. So understand the compensations from the broker that you're hiring before you enter into a renewal or a decision, right? So you should know if they're recommending carrier A, B, C, how would they get paid by A, B, and C, direct and indirect? Because it's going to be different for all of them, and it's not tied to you, right? And that's what you need to figure out. Second thing is gag clause disclosure. So finding out what kind of claims data you're going to receive from that insurance carrier if you're thinking about making a change. And that's another one of those pieces that needs to be negotiated during renewal. And it can happen. They will push back. You just have to keep pushing harder. And the third thing is drug benchmarking, which is called RxDC benchmarking. You're supposed to benchmark the top 50 drugs. And if you were to actually go through that process, you would be looking at different PBMs, likely. But yeah, if people start with those three measures, it is law now. It is compliance. And the amount of government agencies that have the potential to fine you for them is crazy. It's like DOL, IRS, HHS. There's one other one. But there's like 4 government agencies that all overlap in oversight of this problem. So educate yourself on the CAA 2021. Do it. Follow me on LinkedIn. I'm always posting ideas on it.
And for the clients that are over 250 employees, give us kind of your top few questions that they should be asking as their renewal is coming up to find out if there's going to be an opportunity where they should really be taking a long, hard look at their benefit structure and how they would need to call you.
Yeah, I'd say the first thing is push your broker on timing. So, and I would ask them to lay out the timing and structure of their process because truth is they usually don't have a timing calendar for dealing with these things, nor do they have a structure or a process for considering it. So I would be requesting your first renewal at 120 days, good or bad. And usually what happens, like I said, is they'll receive it and they'll hold on to it and work on it because they don't want to present it. But what they should do, that's your company's responsibility. If it's really bad, they need to present it to you, but say, it's okay. Look, this is my data and my positioning. This is what I'm going to go back with. This is where I think you should land based on these factors, right? You want to hear that they have a thought process, a structure, that this is documented, that it's going to be well timed. So 120 days process, and compensation if you don't know that already, which 99% of companies don't. And that right there might show you enough to know, like, all right, I need to start having other decisions. And the third thing, super simple, I would ask them, are you a fiduciary for my healthcare plan? Pretty simple. Like, if you're hiring them, they should be working in your best interests. And I think that's the lowest bar we can set that 95% of brokers out there can't clear.
All right. So if this is giving you a headache, then you need to call Donovan. Donovan, how can people get a hold of you if they want to reach out and they have more questions, if they're 250 and above in terms of employee count and they need your help, if they're below 250 and they want a referral, how can they get a hold of you?
Yeah, LinkedIn's definitely the best way. So LinkedIn, Donovan Ryckis. You can also go to the website, ethosbenefits.com. You can get the documentary from there. We have a new documentary coming out later this year, specifically just on the PBM problem. So that'll be a shorter film, but I would recommend both. It'll give you a great background.
What's the name of that one? I'm curious because I got a couple of good names for you.
Yeah.
Go ahead.
So that one's called Side Effects May Include, and the director's kind of wrapping it up, but we're thinking September, October that'll be released. So I'm releasing kind of an early RSVP list for the premiere. I don't know when that's going to be, but we'll do a web premiere so everybody can come watch it.
Oh, that's great. Thank you so much, Donovan. It's been a pleasure having you with us. So Donovan's contact info is right below wherever you're getting this show in the show notes. You can reach out to him on LinkedIn. We're putting his LinkedIn profile down there. Donovan, thank you. It's been an absolute pleasure. Really informative having you on. We appreciate you.
Thank you, guys. I appreciate it.
Thank you.
All right, that'll do it for this edition of the Inside BS Show. I am Dave Lorenzo, the godfather of growth, and she is
Nikki G.
We'll see you back here again tomorrow, folks. Until then, here's hoping you make a great living and live a great life.